somnolence, sedation, fatigue profile. So in general, the adverse event profiles were similar in the randomized and in the open label trial. So it's like what you saw in the randomized trials was pretty well what you then also saw when you continue to administer this over a 2-year time period. The most common adverse events here: dose-dependent somnolence, headache, fatigue, sedation, upper abdominal pain. Now, in the open label extensions, we have syncopal events reported. That certainly would be a great area of concern. So 2 reported in the Biedermann study, 5 in the Sally study, and also reports of hypotension, 1 in the Biedermann, 13 in the Sally study, cases of bradycardia and tachycardia, which remitted when either in milder cases they continued the treatment or stopped the treatment, and then the phenomena remitted. But that certainly would be something that would have to be really closely monitored when this medication is administered. There was a meta-analysis conducted looking at data from 3 clinical trials, the ones that I already mentioned, Biedermann, Sally. Collins isn't published, so I couldn't really look at that directly. But it turned out that the best predictor of sedation was really treatment duration. So the likelihood of sedation decreased with time. It was not related really to the actual dose or to the magnitude of dose changes. They also concluded that the weight-adjusted dosing is important for most effective symptom control. That would bring us to off-label agents, and there we have the familiar. So I'm not going to go into detail on that. We have bupropion. We have the TCAs available. We still have the regular alpha agonists, and there is actually now an extended release preparation of clonidine under development, and the Clonicel is being reviewed by the FDA, and I was really curious to see if I could find anything. Has anything been determined? I couldn't find anything. I don't know if any of you know any more about that, but so it looks like there will be a extended release clonidine forthcoming. What I did look at a little bit more is the modafinil, and I wanted you to keep that in mind for our discussion. The guidelines at this point mention modafinil. No, the FDA approval was withheld for ADHD due to safety concerns which were the dermatological effects. Where I do think some new and potentially interesting things have happened in the last couple of years is in the area of ADHD medication co-administration studies. And looking at the current guidelines, we don't see anything mentioned specifically about co-administration. But in real life, a lot of co-administration is happening. So it's like in all kind of other situations, the practitioners are doing it. You know, the research funders and the researchers, they can't really get themselves to study it, so people in real life are doing it, and they're doing it on their own, and with all the risks that involves. So co-administration studies, this one is actually, of course, the older one. This is the Tourette Syndrome Study Group study, where they co-administered clonidine and methylphenidate to children with ADHD and tics. And then a newer one is Palumbo et al. They pretty well did a similar design. They co-administered clonidine, methylphenidate, children with ADHD without the tics. And then we have the study by Spencer. This now is open label, whereas these were randomized controlled trials. We have an open label, a co-administration of extended-release guanfacine and psychostimulants, and then Weiland's did a atomoxetine followed by methylphenidate, a two-phase study. These latter two are open label. So the exciting thing in the Tourette syndrome study group was that you saw ASQ teacher ratings significantly improving on clonidine, on the combination, and just on methylphenidate, and that you also had the tic severity lessening even on the methylphenidate condition. So that was an exciting finding, and they found sedation was common when clonidine treatment was involved. And in the Palumbo study now, on the other hand, this previous one was children with tics. In this study here, we now don't have tics, just ADHD. And here we're finding that the teacher ratings do not improve with clonidine. They only improve with methylphenidate. So we see a improvement with methylphenidate, but with clonidine, the teacher ratings, after kind of an initial drop here, they move back up. So in that study, they could not reproduce the effect of clonidine on ADHD based on teacher ratings. However, they did find in the parent ratings, they found an effect of the clonidine versus placebo. You know, and that very likely, as we would think, has to do with the methylphenidate action time period. The parents probably didn't see that anymore. It had worn off, whereas the clonidine was still on board. And this is the same study, just reporting on adverse events. As expected, drowsiness common in clonidine, some bradycardia. They didn't find a suggestion of interaction between clonidine and methylphenidate. But we have to keep in mind small sample sizes here, so something has to be pretty common in order to be picked up in a small study like that. What Spencer did was they recruited children that were on stimulant regimens, were considered suboptimal responders, and then added on guanfacine, kept the stimulant at the same level, added on guanfacine, and were able to, in those who were on methylphenidate regimens, to get an additional drop on their ADHD rating scale of near 18 points if they were on amphetamines, near 14 points. And in that combination, the most common treatment-related AEs here were upper abdominal pain, and then you see some of the expected fatigue, somnolence type of side effects that have been reported for guanfacine. And then when, in Weiland's study, he basically added Concerta to a regimen of atomoxetine and found additional improvement could be achieved by adding the methylphenidate to the regimen, and then reported that they didn't have serious cardiovascular AEs during the study, no changes in atomoxetine levels after they added on the methylphenidate. Very small sample size, only 50 in the picture. Aggression in the context of ADHD, the other brief reflection, because we're going to have a talk on aggression. But in the context of ADHD, I think we need to just keep in mind that when we're dealing with children that are covered under Medicaid, this is a population of families in poverty, so aggression occurs in the context of them having more stressors, and that plays a role in terms of what happens with them neurodevelopmentally and what happens with them as far as role modeling, etc. So we just, I think, can't disregard something as obvious as that. Aggression can also be a treatment emergent side effect, even though stimulants can be helpful with aggression, but they can in some cases actually also lead to aggressive presentations. And then we need to think about age-dependent issues, like in preschoolers, is this somebody